I'm going to go ahead and get started, and I want to extend my thanks on behalf of GE HealthCare who is sponsoring this industry symposium, and welcome each and every one of you for attending. My name is Peter McCullough, and I'm an internist and cardiologist at Baylor University Medical Center in Dallas, Texas, United States. And our topic today is the risk mitigation strategy in the heart catheterization laboratories. I also want to make mention of the Cardiorenal Society of America, which is a society that's in its first 10 years, but much like the efforts that are going on here in Vicenza, it's a forum to bring cardiologists, nephrologists, and critical care doctors together to really advance our knowledge and our care for patients. So let's move on to the heart catheterization laboratory, and a lot of my comments will apply to cardiology, interventional radiology, and to high-risk patients undergoing procedures, largely intra-arterial injections of contrast. And by way of disclosure, I do have a consulting relationship with GE HealthCare for original research projects. So let me make a few comments with respect to the etiology of acute kidney injury as it relates to contrast, go through the pathophysiology and its relationship to outcomes, talk about what has been attempted and what works in terms of prevention, mention the selection of contrast agents, use of intravenous fluid, N-acetylcysteine, in particular, has been studied in great detail, and then make a few summary comments. So the first is about the etiology of acute kidney injury. When we perform procedures, it's important to realize that certain syndromes, acute myocardial infarction itself, can be a cause of acute kidney injury, even in the absence of administration of contrast. And it's thought that through neurohumoral activation and then hemodynamic changes, acute MI, even conservatively managed, can be related to acute kidney injury, but it's relatively infrequent. When we administer iodinated contrast intraarterially through catheters, and this is just showing access through the common femoral artery, through catheters, injecting the contrast and then have the contrast traveling to the kidneys clearly causes a vasoconstrictive chemotoxic injury. But I want to point out that there's also atheromicroembolism with these catheters. The catheters originally, 30 years ago, were about 8 French in size. Now catheters are about 4 or 5 French in size. But every time we do a catheter exchange in the aorta, there is some atherombolism that occurs. And years ago, we did a study, we published it in Circulation, where we collected the back bleeding from the catheter on each exchange, and we analyzed the blood for cholesterol crystals. And there were relatively large cholesterol crystals on about 50% of the samples that that was in over 1,000 cases. So I'm very convinced there's atherombolism that occurs, and it's relatively clinically silent. So part of what we see with the kidneys is due to contrast, and part is due to atherombolism. In the setting of a cardiac catheterization and we're administering contrast, I want you to keep in mind there's increased neurohormones, decreased renal blood flow. There is a release of labile iron that occurs in the setting of acute myocardial infarction, and this has been demonstrated. There's a contribution of atherombolism I've mentioned, and then there's prolonged stasis of contrast in the peritubular space. Remember, contrast is very water soluble. When we administer it, many times we have inadequate time for prophylaxis. There's hemodynamic instability, and in particular in the setting of urgent PCI, because we're constantly testing and retesting the position of our catheters and stents, we can end up with relatively higher contrast volumes. But contrast is freely filtered in the glomerulus, and then it tends to reside in the peritubular space and can be there for quite some period of time. The clinical data have always been very impressive about baseline renal function predicting outcomes. Now, all of these patients in the Cadillac trial had ST segment elevation myocardial infarction, and this is just the baseline creatinine clearance. But the point is that creatinine clearance could separate by nearly 40 points on a one-year survival curve. That's the greatest separation of survival curves that I'm aware of in acute MI. It separates survival curves way better than ejection fraction, way better than any biomarker, including LDL cholesterol or C-reactive protein. There's no doubt about it that renal function is the hyperdominant variable on survival in acute myocardial infarction. And conversely, patients with a creatinine clearance over 60, and these are all patients with ST segment elevation MI, they have about a 99% survival out to a year. So renal function is kind of the golden variable, if you will, as we move to the heart catheterization laboratory. And in this trial, just as one example, about 16% of patients the 30-day mortality of those who developed contrast-induced acute kidney injury was 16.2% compared to 1.2% without any contrast-induced acute kidney injury. And then you can see the one-year mortality here. So the point is from this study, and many have shown this, is that baseline renal function anticipates mortality, and then clearly those who develop acute kidney injury, there's a strong association with mortality. Now this was published over 15 years ago, and if we fast forward to contemporary data from the US CATH PCI registry, where there's over 1 million patients in this registry that have undergone coronary angiography, you can see a sharp relationship, and this is AKIN stands for acute kidney injury, that you can see that death, bleeding, as well as recurrent MI are associated with those who develop contrast-induced acute kidney injury. So by proxy, the patients who develop this problem clearly are at risk for other complications. Okay. In the United States, as a quality metric, we have risk-adjusted AKI rates that are reported per hospital. So here's an example of a hospital and the ranking of where this hospital is in terms of percentiles. So we do get a score in the United States, and so it is being kept track of by the American College of Cardiology. So that ushers in some comments regarding the evolution of contrast media. We're highly dependent on contrast media in the heart catheterization laboratory. 30 years ago or more, high osmolar contrast agents were the standard. And as these contrast agents have been refined over time, low osmolar contrast agents became the standard. And then in the 1990s, a single isoosmolar contrast agent, iodixonol, was developed. And of interest, it was a way of configuring these two benzene rings to have not only sufficient iodine on them for radio opacity, but also have the configuration for osmolality. So it had the same osmolality of blood. And as I'll share with you, that's attractive from a chemophysiologic perspective. High osmolar contrast always creates the most crenulation of cells, creates the greatest amount of symptoms when administered. One can feel this being injected in the body, whereas isoosmolar always provided the least amount of symptoms, the less amount of crenulation, the least amount of destabilization of mast cells and basophils. And so therefore I've always had with these agents the lowest rates of anaphylactoid reactions. Now there's a relationship that's well understood regarding the amount of contrast volume and the risk of patients developing contrast-induced acute kidney injury. In fact, the risk of patients going on to dialysis after contrast injury, which is always small, typically less than 1% or 1% would be the highest. But you can get the idea of just comparing the contrast volume divided by a measure of renal filtration. It gives one a sense of where we are in terms of volume. So if a patient had an estimated GFR or a creatinine clearance of 30, and if we gave 150 cc's of contrast, we could be well up in this relationship where there could be a risk of a really serious renal failure. Patients who have much better renal reserve can handle very significant volumes of contrast. Here are the data regarding contrast volume thresholds in the published studies. Lansky, which is the one I just showed you, that was from the National Institutes of Health, the dynamic registry. But they've all settled somewhere on 3 to 5 mLs per milliliter of GFR. Now, in terms of pathophysiology, I think the important points I'd want you to understand is that when contrast is administered, there is clearly a relatively early vasoconstrictive phase that happens, and it typically happens in the outer medulla, where the oxygen tension is already low around the proximal tubule, as well as the early part of the distal convoluted tubule. And there's been a considerable research here to suggest that when contrast injures renal tubular cells, there is really a cell-to-cell reaction that occurs, including release of free radicals and changes with oxidative stress, where the contrast is out of the urinary lumen. There is a cell-to-cell kind of chemotoxic wavefront of injury. Contrast itself in just cell preparations is chemotoxic. And when we add the vasoconstrictive phase, which can last, in a normal kidney, the vasoconstrictive phase only lasts a few seconds to a few minutes. But in patients who have diabetes and kidney disease, the vasoconstriction that occurs within the kidney can last for an hour or more. You combine those two factors, there is this kind of vasoconstrictive hypoxic injury and chemotoxic injury to the kidneys. So here's a normal kidney tubular cell on the brush border. You can see the cell superstructure here. These are the anchoring desmosomes, or what's called placans. And then this is the basolateral space. And the theory is with contrast, that contrast is very water soluble. It's taken up by proximal tubular cells. It clearly gets into the peritubular space. You can start to see destruction of the brush border and all kinds of cellular changes indicating injury to the tubular cells. And there's been 4 or 5 observational studies that by chance have gotten imaging after contrast exposure, and has shown us how long contrast can stay in the kidney. So here's one case report. 73-year-old patient with multiple myeloma had a contrast administration by CT. Baseline creatinine was 2.3 milligrams per deciliter, creatinine clearance 23. There was a creatinine rise of greater than 0.3 milligrams per deciliter, so there was acute kidney injury. Here's a bolus of contrast, and you can see this in the inferior vena cava. You can see contrast in the renal cortices. But 3 days later, for a non-contrast study, you see really pretty clear retention of contrast in the renal cortex. 8 days later, there's still some there. And it's not until about 17 days later, by chance, they had this follow-up scan where the contrast is gone. But the point is, contrast in patients with impaired kidney function, I think that is there for days or at least a week in the kidneys. And so our attempts at giving a prophylactic agent for a couple of days, in my view, have been foolhardy. And almost all the chemoprophylactic programs I'm involved with now, we're giving protective drugs over a much longer period of time because of this contrast retention issue. The contrast is pretty clearly not in the arterioles, and it's not in the venules, and it's not in the collecting duct, because we don't see contrast in the urinary bladder afterwards. The contrast is actually stuck in this area called the peritubular space. This is the zone of contrast injury. And there's been attempts at looking at a variety of biomarkers. I'm going to talk about this later on today. We rely on serum creatinine for an acute change. One could also rely on cystatin C. The markers, the cell cycle and rest markers, including IGF-BP7 and TIMP2, have not been formally assessed in contrast. But there isn't much enthusiasm for them since they appear to be really ideally positioned as sepsis markers. Data with respect to KIM1 as well as alpha GST, PIST, and IL-18 have not been favorable, and I've done some of this work. The one that I would call out your attention to that looks quite favorable is L-type fatty acid binding protein, and this is moving forward now as a acute point-of-care diagnostic test for contrast-induced acute kidney injury in pivotal studies being undertaken in Japan. So look forward to that in the future. In this New England Journal of Medicine paper, it was pointed out that normal kidney tubules are taken here in cross-section, and in the setting of injury, there is actually damage and sloughing of these cells. But importantly, around the rim of these cells, there are recovery cells, in a sense, nascent tubular stem cells that will recover the tubules. And the theory is there's always injury and recovery, and recovery, and that as long as the tubule superstructure stays intact, that there should be sufficient recovery in order for a patient to bounce back to where they were at baseline. Probably very different from sepsis and cardiogenic shock, these other areas where there is really frank necrosis of large segments of tubules and nephrons where there may not be sufficient recovery. I wanted to point out that there is a particularly high-risk area to consider, and that's the scenario where patients undergo an angiogram and then move right into cardiac surgery. And this was a research that was supported by an independent grant from GE, and this was done at Baylor at our center. And these were all patients who were high risk. They had all received iodexonol. They underwent angiography, and then we separated them out based on time. And from the time of the angiogram to the time that they had cardiac surgery, which was largely a coronary artery bypass surgery. And this is the endpoint here is MARSEILles, which is major adverse renal and cardiac events. So this is the composite of renal replacement therapy, recurrent MI, stroke, heart failure, renal or cardiac hospitalization, or death. And you can see it's most favorable once we get to about 5 days in between the contrast and the surgery. But when we give contrast and we move right into a surgery later that day or the next day, the outcomes are much worse. Now, many times these are very sick patients that have critical left main disease or three-vessel disease. In the surgery, we know going into it is high risk. But in this paper we published in the surgical literature, if a patient is developing contrast-induced acute kidney injury and they go right on to surgery, it's basically a disaster for this patient. The mortality rates are sky high. The hard clinical event rates are sky high. And when we reviewed these cases, we found about 15% of cases, when we looked at them, the patients could have waited. That we could have, in a sense, given some time in between the angiogram and the surgery to probably better plan and allow for some renal recovery. So think about this when you're in a situation where there's an angiogram followed right on by surgery, the highest risk scenario that we found. Now, what about approaches to prevention? What do we know here? Well, there's some good news with respect to transradial coronary angiography and PCI. So radial artery PCI in the United States has really taken off over the last 10 or 15 years. It started at our hospital in 2008. And I recognize some centers in Europe as well as Asia have been doing this for quite some time. I visited cath labs in China, for instance, where they exclusively use the radial artery. They almost don't know how to access the femoral artery. But what you need to know here is, and these data come from the MATRIX AKI study, is that radial artery compared to femoral artery has always shown a lower rate of acute kidney injury, no matter how it's classified by KDIGO stages or by a composite endpoint. Now, the risk reductions aren't huge, but in general, it's about a 15% risk reduction when a radial artery cath is done, even if the same contrast volume is administered. And this is probably this issue of catheter exchanges and cholesterol microembolism feature. So believe it or not, our highest risk patients, I'd rather have a radial artery approach. What else has been tried? Well, there's attempts to increase renal blood flow even with forced hydration. And the group in Milan has done a lot of work with something called the renal guard device, which administers intravenous fluid even up to 600 cc's an hour, and attempts to get a urine output up to 600 cc's an hour using this approach. There are attempts to attenuate inflammation or oxidation by using bicarbonate, and I'll just tell you that unfortunately has failed. There are attempts to reduce the direct cellular cytotoxicity to the nephron by trying to dialyze the same day, trying to physically remove contrast. That has failed. There has been attempts to reduce extravasation into the peritubular space by creating a congener of contrast with something called cyclodextran, which is a molecule that works as a solubilizer. That actually is encouraging. It's moving forward now with a collaborative that's occurred between a manufacturer of contrast and a company that specializes in this cyclodextran technology. But suffice it to say, we really need to be using the best contrast and the lowest volume of the best contrast because we don't have bona fide preventive approaches. Having said that, these data come from one of the big electronic medical record companies in the United States. There's clearly been a reduction over time of contrast-induced acute kidney injury from what we can see in the literature. Rates used to be as high as a quarter, now going down to about in 2008, about 19. The current number in today's era is 15% or less developed of patients undergoing a PCI for acute myocardial infarction develop contrast-induced acute kidney injury. There's been a lot of work done on the selection of contrast, particularly the isoosmolar contrast versus low osmolar contrast. The most recent meta-analysis came in about 7 or 8 years ago, where we had direct head-to-head clinical trials that measured the serum creatinine at the same time point to get the highest quality data here. And I can share with you of the 25 intra-arterial trials where contrast-induced acute kidney injury was the pre-specified endpoint, and it was a head-to-head randomized controlled trial, that the overall hazard ratio was in favor of isoosmolar contrast. It was a 54% risk reduction in this analysis. Subsequent studies have all demonstrated this. The only way where a meta-analysis has been erosive in terms of this differential is when they've included observational studies, included studies that weren't head-to-head, or included studies where creatinine was measured at different time points and introduced a ton of variation. But you can see here the confidence intervals are tight and the relative risk reduction is large. Hazard ratio is low. And these are the highest quality data that I'm aware of in aggregate supporting the use of iodixonol as the agent in patients at risk for contrast-induced acute kidney injury. There's been a similar meta-analysis concerning pain and warmth. So not looking at the renal outcomes, and these are largely in patients getting peripheral injections for peripheral arterial disease, and diagnostic angiography, particularly cerebral or extremity angiography. And what this template is showing you is a stacked bar graph of patients' report on pain, change in temperature, and discomfort. And the summary is that pain, warmth, and discomfort occur with cerebral and peripheral injections of contrast. Iodixonol was associated with about a 90% reduction in the symptoms compared to low osmolar contrast agents. And so here, it's not looking at the kidneys at risk and just simply the comfort of the patient. And so there are many radiology departments that for these injections only use iodixonol. So at our institution, our vascular surgeons do these injections and they exclusively use iodixonol. They will not use a low osmolar contrast agent. We've gone further and looked at the rates of major adverse renal and cardiovascular events in large hospital systems in terms of what it means economically. And the answer is that these Marseille events occur in about 5 to 10% of patients. iodixonol-only strategy. So these hospitals that only use iodixonol for high-risk patients result in substantial cost savings to health systems. Makes sense because rehospitalizations are avoided. There have been attempts at actually trying to use contrast-saving devices. So there are devices in the cath lab that are counting every single milliliter that's injected, and even the test injections, as well as modulators to prevent the doctors who are using a manifold to prevent over-injection. These have been tested, and I don't have the summary here, but the bottom line is these systems have failed to sufficiently reduce contrast volume administration in heart catheterization laboratory. And so it's still up to the doctor to consciously make decisions in terms of how to set up the shots, if one is going to use biplane or single plane angiography. And probably the most important thing is skipping the left ventriculogram, which is an opportunity to save about 30 to 40 cc's of contrast. This was a really strong attempt in using a lot of advanced technology in the cath lab, and unfortunately it didn't. Intravenous fluid, given short-term prior to angiography, does work, and here's the Poseidon trial. These are patients estimated GFR below 60, and they had LV EDP guided hydration, so put up a catheter in the left ventricle, measured left ventricular end diastolic pressure, and then administered normal saline according to the LV EDP versus standard normal saline, and this is the primary endpoint. The pre-procedure protocol was 3 mLs per kilogram bolus, so for an 80 kilogram person, this would be about a 250 cc bolus 1 hour before, and then LV EDP guided volume administration during the procedure. And the LV EDP guided administration simply tried to avoid giving a high volume in a patient with a high LV EDP. Is simply what's in pink here is basically to prevent putting a patient into heart failure compared to a standard approach. Many of your laboratories don't even use a standard approach, and this works quite well, honestly, of just giving a 250 cc bolus of normal saline or Ringer's lactate, any isotonic crystalloid, before the procedure, and just running the IV during the contrast administration. But this is much more aggressive here. So this is a 250 bolus and then 250 an hour while we're in the catheterization laboratory. Actually, more than that. This would be about 300, 400 an hour in the catheterization laboratory. But this was the Poseidon trial. The baseline creatinine is 1.4, eGFR 48. You can see the other parameters. And here was the rate of contrast-induced acute kidney injury. So it clearly works. Administering fluid is probably the single thing you can do as a consultant, but it's very short-term, right before the procedure. Studies of giving half normal saline 12 hours overnight or normal saline, that doesn't work. Don't bother doing that. Will simply just cause more problems with excess fluid administration. It's very short-term, and it's probably just forcing a bit of a diuresis, a saline diuresis, and getting some contrast out through the urine. N-acetylcysteine, which rejuvenates glutathione, was tested in the ACT trial. And in the ACT trial, this was 2308 patients. They were undergoing, about a quarter underwent PCI, the rest angiography. N-acetylcysteine 1200 BID for a total of 4 doses. And the answer was no difference whatsoever in the rates of contrast-induced acute kidney injury, 12.7 versus 12.7%. This was tested in a further trial in the U.S. called the PRESERVE trial in the VA, a much larger trial, 4,993 patients. The N-acetylcysteine was given now for 5 days, so for a longer period of time. And here, the rates of acute kidney injury were no different, 4.7 versus 4.4%. They had a much stricter definition of the primary outcome, which was death, dialysis, a persistent 50% rise in creatinine at 90 to 104 days, and even more conventional, easier to meet endpoints were no different between this. So N-acetylcysteine clearly doesn't work, and I think it can be abandoned. So to finish and conclude, this was the central illustration from the review paper in JCC now in 2016. I do this about every 5 years to update the cardiology community. And this is what we came up with. So estimated GFR over 60, really just good clinical practice. I don't think anything special needs to occur in these patients. GFR 30 to 60, the thought was here to ensure statin use, which has a preventive effect. Pre-procedure IV volume expansion. This is this 250 cc bolus before patients go into the procedure. And then the LV-EDP guided clinical management. If patients have acute coronary syndrome, have diabetes, heart failure, undergoing TAVR, which is percutaneous aortic valve replacement, we recommended isoosmolar contrast. When the GFR is below 30, the recommendation is isoosmolar contrast for all these patients, and then to have nephrology involved regarding pre- and post-procedure planning. And that's kind of the general theme. Above 60, there's really no specific risks, but below that area, we believe the risks begin to accrue. So this is my final slide. I think the pivotal question in this field that we've been pursuing for years is if we can prevent contrast-induced acute kidney injury, if we can basically make this problem go away completely, will we reduce rates of clinically meaningful events, including death, dialysis, rehospitalization, heart failure, acute coronary syndromes, arrhythmia, and stroke? And if this happens, are we changing the long-term prognosis, and by what mechanisms? I've shared with you that these patients, all the way from having more senescent cells, greater amount of risk factors, older, more feeble, more frail, they're more likely to develop contrast-induced acute kidney injury. Is contrast-induced acute kidney injury really just a proxy variable for other things that are going to happen? It's all kind of true and unrelated, or in fact, is it indeed related? And we'll only know when we get to this kind of key part of the slide with either an entirely non-toxic contrast agent or with an entirely preventive medicinal approach. And I'm actively working on both of these right now. In the United States, the estimate are there's about 30 million contrast administrations given per year. It's an extraordinary number, with the pool of cancer patients kind of steadily expanding, the pool of cardiovascular patients expanding. Even though rates of coronary angiography and PCI are going down, globally rates of contrast administration, in my view, are probably going up. The single most erosive argument I've heard on this topic in the last few years is that contrast-induced acute kidney injury doesn't exist. And you may have heard about this, someone shaking their head in the front row. And this came actually from the Mayo Clinic and from the Department of Radiology, in my view, through some sloppy epidemiology. That if you look at hospitalized patients and you look at patients undergoing contrast or non-contrast CTs, where creatinine is gathered for clinical reasons, but not in a consistent way, and you have lots of variation and lots of sloppiness in the data, one cannot see a signal, if you will, of contrast and changes in renal function. But as I've shared with you, in prospective randomized trials where we have a clean baseline and we measure creatinine over time, the problem always exists. So I've made the case that the randomized trials clearly take priority and supersede sloppy epidemiology. And I don't believe what McDonald is doing from the Mayo Clinic one bit. I've heard people say, well, listen, we don't need to worry about the problem. The problem doesn't exist. The problem's gone away. And I said, okay, well, in the United States, that's your next big lawsuit if you're going to make the case that this problem doesn't exist. Because we have randomized trials clearly showing the problem exists. Now, it exists to a greater degree with intraarterial injection compared to intravenous injection, but it still exists with intravenous injection. If patients get enough contrast and they're at a high enough risk, this problem occurs. And there's been prospective randomized trials on the venous side as well. So I'll let that be the last word. I want to thank you for your attention today, and thanks for your patience in our slow start.